Today we are talking about several of the central questions of the abortion issue. Is abortion ever needed to save the life of the mother? And in the case of a terminal diagnosis for an unborn child, is an abortion saving the mother and child from suffering? This is one of the so-called hard cases where many people think that abortion is the way to go. But is abortion really respecting both the dignity of the unborn child and his or her mother as a human being? And also, when do unborn children feel pain? Here to discuss all of these questions with me today is Dr. Kendra Kolb, a practicing neonatologist who is dual board certified in pediatrics and neonatal perinatal medicine. She has done work for Live Action and Students for Life of America and is a member on the board of directors of her local pregnancy resource center. She is also a mother of 3. Dr. Kolb, thank you so much for coming on the show.
Yes, thank you, Sherry, for having me. I really appreciate the invitation, and I'm passionate about the topic that we're going to address today, so thank you for having me.
Yes, so I would like to really dive into our first topic, which is the so-called life of the mother instance, because this is one of the most frequently brought up reasons for why abortion should be legal, and also for a justification for abortion being seen as a medical procedure. So is this ever really the case? Do we ever need an abortion to save the life of a mother?
Right, so the simple answer is no. And it's important to kind of first start by talking about definitions and terminology and being clear with language. So we know that certainly there are various pregnancy-related complications that will lead to either a miscarriage, which is the natural death of a baby prior to 20 weeks, or will necessitate a preterm delivery, which occurs sometime after the point of viability, which is about 21 to 23 weeks of gestation. So again, certainly in both of these situations, sometimes tragically babies do die either prior to or during the delivery process or shortly after the delivery process. Certainly also there is a maternal condition called nectopic pregnancy, where the baby will implant into the fallopian tube most commonly or somewhere outside of the uterus, which again is a situation that is an inevitable miscarriage. Again, a natural death prior to 20 weeks, which can, jeopardize the life of the mother through hemorrhaging and, fatal bleeding. So again, certainly there are pregnancy-related complications that need to be managed. But the question is, it's clearly a question of intent. The Supreme Court has multiple times defined abortion to be a procedure which intentionally and directly is performed in order to end the life of the baby. Again, that's much different from, miscarriage management, which is, managing a pregnancy after the baby has died, or again, managing an ectopic pregnancy, which is a baby who will inevitably miscarry and again, threaten the life of the mother. So, also there's certain conditions, such as maternal cancer, where she may need to take medications such as chemotherapy, again, may also result in a miscarriage. But again, the intent of the medication was not to kill the baby. So again, that would not be classified as an abortion. So again, abortion, we really have to be careful and clear and precise with exactly what we're talking about. Very often the media will try to kind of spin, miscarriage management as abortion, which is just clearly deceptive. Those in the pro-life movement understand, again, that naturally, sometimes babies, will pass, again, either prior to or shortly after delivery. But again, this is, and our laws also clearly distinguish between, natural death from natural causes, as opposed to homicide. Again, it is a question of intent. The question being, was the purpose of this procedure to produce a dead baby? If the answer is yes, that is an abortion, and that is not necessary.
Yes, and it's also very important to highlight that, of course, not only is the doctor's intent different, but the very procedure itself is completely different. So could you explain to us, how is it different, an abortion, from separating a mother and child in some kind of high-risk pregnancy situation?
Exactly. An abortion procedure is a surgical procedure. There's different ways to, to do an abortion. One is the mother taking medication. The first medication would be a drug called mifepristone, which blocks the actions of progesterone and causes the baby to die. And then a second medication, misoprostol, which is used to cause uterine contractions to expel the dead baby. So again, that is one way abortion can be done. That typically is used to terminate pregnancies prior to 10 weeks gestation, as opposed to pregnancies that are a little further along, would be surgically aborted with most commonly a procedure called a D&E procedure, where the baby is pulled out in pieces through the cervix. Sometimes the babies are killed ahead of time with a medication that's injected either into the chest or the heart of the baby or into the head of the baby to cause the heart to stop, the baby to die, and then the baby is pulled out in pieces through the cervix. But there's risk in doing, in injecting feticide into the baby for the concerns that it may enter the maternal circulation and cause maternal cardiac arrest. So some of these babies are just dismembered alive. We may get to this later a little bit more, but it's kind of a natural segue into the topic of fetal pain. Just recently, one of the Journal of Medical Ethics published a paper in 2020 called Reconsidering Fetal Pain. And experts in fetal pain agree that even as early as about 12 to 15 weeks gestation, babies do have, the necessary neural connections and neurologic structures to be able to process pain. Previously, it had been argued that, the cortex is not fully formed in babies that early. But now we have definitive evidence to say that babies, even as early as 12 to 15 weeks, will demonstrate the same stress responses to painful stimuli that an adult would, which is facial grimacing, increase in heart rate, increase in cortisol levels. So again, when we're considering fetal pain and considering that babies start to be able to experience pain at the same gestational ages that they are being surgically aborted, this is a critical thing to understand. We sometimes, again, those will argue, well, we should, abort the baby with certain conditions so that, again, we alleviate or prevent them from ever having to suffer. But that's just, it's dishonest to present that as an option, because even, again, just the injection of, the feticide into either the head or the heart would be expected at those gestational ages to be very painful for babies, to be very stressful for those babies. So I think it's really important that we fully educate the public on this topic of fetal pain and how early these babies can experience pain and discomfort.
Yes, absolutely. I mean, it's truly unbelievable. And, before we talk about the question of terminally ill children, I do want to ask that frequently you touched upon ectopic pregnancies, that people also don't understand why treating an ectopic pregnancy is not an abortion. So how is that different? How is the dignity of the child also respected in the procedure to treat it?
Right. So again, ectopic pregnancy being when the baby implants somewhere outside of the uterine cavity. So only the uterine cavity, has the capability to sustain a baby, to term or even to the point of viability. Ectopic pregnancies will typically rupture sometime between 6 and 16 weeks gestation, which is much too early for, a baby to survive at that point. Again, the limits of viability being very youngest between 21 to 23 weeks gestation. So we're talking about an inevitable miscarriage. This is a time bomb. This baby, will not survive in that location and does need to be removed from the fallopian tube prior to rupture, when again mom can experience, fatal bleeding and hemorrhaging. So again, our intent in treating an ectopic pregnancy, is not primarily to kill the child. The intent is to remove the child from the location where we know they're going to miscarry. So again, it really is the difference between managing a miscarriage and intentionally killing a baby for the purpose of producing a dead baby.
Yes. And another question with regard to medical abortions is this so-called selective reduction abortions, which I have heard doctors recommending women who are pregnant with multiple babies, i.e., twins, triplets, etc. Why are they recommending this? Is this ever in fact necessary?
Right. So, in recent years, especially with the assistance of, assisted reproductive technologies such as in vitro fertilization, in utero insemination, and particularly in cases where women are given medications to make them hyperovulate or ovulate more than one egg at one time. Again, if all of these eggs are fertilized and, go on to develop, you have a situation again where you may have a woman carrying, 3, 4, 5, embryos at the same time. So, multiple pregnancies are considered a higher risk pregnancy. They can result in preterm deliveries, low birth weight babies that, may go on to have some complications, which is why sometimes, again, providers will offer these selective reductions. The flip side of that is, while it may be, to some degree higher risk to carry more than one baby at a time, these selective reductions are put women at a much higher risk for miscarriage in general. The miscarriage rates with selective reduction can be as high as 33%. Your chance of losing all the babies. So you're really exchanging the risks of prematurity and low birth weight for the risk of miscarriage, which again is not a small risk in these cases. When you look at the procedure itself, it's very graphic, it's very gruesome in some ways when again you really walk through all the steps. So these reductions are typically offered and done somewhere between 7 and 8 weeks gestation. A needle will be introduced through the vagina and then entered into the chest of the baby, visualized using ultrasound technology, so that a medication that will stop the beating heart of the baby is administered, and the baby will then die. That's pretty graphic. The question of, are parents really aware of, the development of their baby even that early, and are they aware again that they are going to selectively target one of these babies by injecting a medication into their chest, into their heart, to stop their beating heart? Or is it kind of a procedure that's described more euphemistically? When we look at fetal development, and again, something that's very poorly understood by the general public, by 5 weeks, a baby has a beating heart. By 6 weeks, the face is starting to take shape. By 8 weeks, the baby has distinct fingers, is moving their hands and their arms. 9 weeks, the baby has distinct toes, is moving their legs. By 10 weeks, they're very active. They're moving their head, they're touching their face. So this procedure is performed in that time period, again, between about 7 and 9 weeks or so. And specifically stated in this way because the babies are, quote, the fetuses are less physically active at this time. So you have a live baby that you're able to target their chest to inject a drug to kill them. Again, this is not some kind of waving of a magic wand. I mean, this is choosing one of the babies for death, and a baby at a time when they have distinct fingers and toes and are able to move their arms and their legs. That it again, the reality of that, how often is that being discussed? Probably not often, because unfortunately the general public is so poorly educated on fetal development and really understanding, what exactly we're talking about here.
Yes, I completely agree. It's the reality of both the unborn child and what abortion does to this child, I think truly would convince the broad majority of people that this cannot be okay in any situation. But one of the situations in which it is justified for is what you referred to earlier, with children who are diagnosed to die soon after birth, or even in situations where they have certain maybe conditions that are predicted to cause them suffering after they are born. So, what are these most common conditions, and how frequent are they?
Sure. So in the past, again, these conditions had been labeled as quote lethal. Recently, in the last few decades, the palliative care field, again, it's a field of medicine that deals with end of life issues, which again, we know end of life can happen all along the spectrum, from in the womb to the tomb. Again, palliative care, is a specialty that deals with all these issues. So again, the more appropriate term that we've been using is something called a life-limiting diagnosis, for the reason that it can be very difficult to predict with total accuracy the lifespan, or again, quality of life, for children diagnosed with many of these conditions, again, that are screened for, or found prenatally. So again, these conditions occur in about 1 to 2% of pregnancies, and again, are expected to at least shorten the life expectancy of that child. But again, a lot of them can be very difficult to pinpoint with exact specificity, how long the child will live, especially some of the more rare genetic conditions such as trisomy 13, trisomy 18, and trisomy 21. So some of these life-limiting conditions, again, we have the genetic conditions, which may shorten the life expectancy, but we also have some kind of anatomic conditions, which would be expected to shorten the baby's life, such as, issues with major organ structures, such as the head, a condition called anencephaly, in which portions of the skull or the actual brain tissue are, impacted, major issues with the heart, the lungs. Sometimes the lungs are very underdeveloped for various reasons, issues with the kidneys. Sometimes the kidneys are absent, either one or both. So again, we're talking about, major organ abnormalities, that are expected to, adversely impact, the lifespan of the baby.
Yes, and the central question that always comes up with these children is suffering, right? And firstly, I'm wondering, do these children suffer because of these different conditions already in the womb? And when parents believe or are often told that abortion is the merciful option because they are preserving their child from suffering, how true is that of a statement?
Right. So, I think first off, it's, pertinent here to talk, about, the uncertainty of some of the, in utero screens that we do. So, during the first trimester, mothers are offered the chance to obtain, genetic screening. But again, the word is screening. This is not a diagnosis. Many of these tests are unfortunately very inaccurate, especially for some of the more rare genetic conditions that have such a low kind of pre-test probability of being correct in the first place because they are so rare. So in the case where one of these screens results positive, and again, some of these screens for some of these more rare genetic conditions have, a false, positive rate up to 80 to 90%. The New York Times just last year on this time reported. Again, if there is a positive screen, that needs to be confirmed with a diagnostic test, such as an amniocentesis. And unfortunately, a lot of parents are encouraged to abort just based on the results of a screen. And again, we talked about some of these more rare conditions, especially some of the genetic conditions. Medical providers have a very skewed perspective of as compared to, the experience of some of the parents who have chosen to carry their babies to term. Again, conditions such as trisomy 18, trisomy 13, again, the life expectancy for that child is variable. It is a, individual case by case scenario. But some of those babies have gone to live on for years and years with a much better quality of life than what the parents were told when they were given that diagnosis prenatally. I can think of one mother in particular who's an outspoken advocate for babies with trisomy 13 and 18. Her daughter was 3 at the time when she did most of her advocacy work. And again, she says, the greatest, tragedy would have been never meeting my daughter, Evelyn, who has given us so much joy. Many of these parents will say, my child is happy. My child, has purpose in our family, has given us joy. When they were only painted the gloom and doom picture of suffering, prenatally. So again, some of our perceptions as physicians of quality of life, of suffering, are really not consistent with reality when you talk to some of these parents who, yes, their child may be severely developmentally delayed, but is still capable of love, of interaction. So again, that also kind of really clouds the picture and this issue, especially when you're looking at certain genetic issues. When you're looking at certain anatomic major organ system issues, again, typically, babies in the womb are very comfortable. They're kind of freely moving in this aquatic, warm environment, listening to their mother's voice. They're able to hear as early as about 16 weeks or so. They're really not, quote, suffering in utero in the way that maybe some parents are told. Certainly after delivery, there are things we can do. Again, using medications, using palliative care, which, we could talk about a little bit later, to alleviate suffering. But again, typically the womb is a very comfortable place for these babies to be, even those with very severe conditions. Talking about suffering, it's a very kind of broad issue. Some of these babies who have issues such as congenital diaphragmatic hernia, spina bifida, can even benefit from in utero surgery. So again, some providers are really just painting gloom and doom for situations that do have some hope. And again, at the very least, these babies would be candidates for palliative care, providing pain medication, sedation, oxygen as needed, nutrition as needed and indicated, and again, making a very individualized plan for that baby, whatever their issues and needs are, to address them again as a human being with dignity, as opposed to, killing them through an abortion procedure at a stage where likely they can feel pain and they can suffer, and nothing is being done to address that issue.
Yes. So, what does this ethical alternative in palliative care look like? Could you tell us a bit more about it, and also how maybe the parents are also accompanied and included in this journey?
Sure. I want to start off by saying, this discussion, is not meant to add to the grief or the guilt for parents who have chosen abortion for, a child with a life-limiting diagnosis. We know statistically speaking that most parents have never even heard the word palliative care, were never offered this option for their child. And, it's secondary to really a lack of understanding that this is available, even starting in the in utero period. So the field of neonatal or perinatal palliative care really has been developing over the past few decades rapidly, and provides individualized care for babies, again, who are diagnosed, not just screened, with a particular, life-limiting condition. Again, we're talking genetic issues, anatomic issues, major organ issues, where the baby, that are incurable, but the parents want to still continue to carry the baby. But we've shown it's the palliative care literature, perinatal palliative care literature has, shown time and time again that parents who choose the palliative care option, statistically speaking, cope much better, with the loss of their child. Again, if it's a condition where they're not able to benefit from medical support, again, they are given the opportunity to plan for the birth, have the support people that there who are needed, again, to have pastoral support, social services, kind of deal with the mental health issue. that these families go through, provide all that kind of support, and also again kind of doing some memory making with the baby prior to passing, bonding with the baby, and again, really meticulously managing symptoms of pain. So again, monitoring the baby closely for signs of pain, providing pain medications to alleviate suffering, providing oxygen as needed, nutrition as indicated, and again, really looking at the family as a whole and making sure we're addressing their needs as well. So again, any baby with a life-limiting condition is a candidate for palliative care. Certainly, we don't want to be doing procedures and interventions that are only going to prolong suffering for the babies. But again, some of these babies are in a gray zone where they really surprise us. And again, some go on to live for years and years as a happy member of their home. So again, these measures, the palliative care measures can, exist alongside curative measures when indicated. So it's a really individualized, tailored plan to each baby and family's needs. The parents' wishes are, acknowledged, are, included in this plan. So really, the parents are in control of making, most of these decisions with our support. I was a member of the palliative care team at my previous institution, walked alongside in particular one case that, was so beautiful. It was, again, a tragic situation, a baby who was, essentially did not have kidneys. So again, that is a fatal diagnosis. There's no question there that baby will not survive. But this family chose the palliative care route, delivered their baby through C-section at around 34 weeks, spent hours with their baby, held their baby as their baby passed. And again, just the look of complete peace on this family's face was bewildering. Again, you would expect, these people to be besides themselves. Of course, there was sadness mixed in. But again, their experience really is consistent with the experiences of other parents in the palliative care literature that say, they were so grateful for the experience that they had, for the chance that they had to meet their child, hold their child as, as they passed. Some of them, report improvement in, different relationship issues, spiritual improvement, and again, mentally seem to cope much better going the palliative care route, as opposed to parents who choose pregnancy termination often deal with profound guilt related to that, the weight of having to make that decision. And again, are not, given all the supportive services that families who choose the palliative care route were given. So again, something that really the general public needs to be more educated about, and medical providers need to be more honest in discussing this option with mothers carrying babies with these life-limiting conditions. Because again, many of these parents would have chosen that route had it been offered to them.
Yes, and I also find it astonishing, the public narrative on this issue specifically, because abortion is presented as the merciful, the easier option, both for the child and the mother as well. And people think that, I found this quote on a YouTube video which I think really summarizes this attitude. Someone saying, "No one wants to carry to term a baby that will die upon arrival or die inside you." And I think that's just really, really sad reading that, because in an abortion, the baby dies inside of you as well, but in the most horrific, violent way imaginable. And it would be really interesting. Have you yourself seen sort of some of the key differences maybe between how parents who chose to abort versus those who carried their children to term, not only afterwards in grieving and saying goodbye, but what was that pregnancy like for them after they knew that probably after birth they only had a few minutes to hold that child in their arms? How were they able to go through those months? What was it like for them?
Right. So again, we do hear the narrative that abortion is the compassionate option for these babies. But again, interestingly enough, we never hear the word perinatal palliative care. This is a medical discipline that exists for these babies to give them a humane passing, again, if they are to pass, or supports them, through their lifespan. So it's a very one-sided picture here to say, oh, well, abortion's the compassionate option. By saying option, implies that you gave them a choice. Many of these parents will say, I, got the diagnosis and they signed me up for the abortion the next day. Never were they offered anything other than abortion, which, is really not pro-choice. That's pro-abortion. So we're really not being honest, and in framing, the context of this discussion, we're not uniformly giving these parents the choice to continue to carry. Again, looking at the palliative care literature, the majority of parents who were given a life-limiting diagnosis were pressured to abort, felt pressured to abort. Even those who said, I want to choose, to continue to carry, some of those parents were, made to feel guilty, their medical provider, abandoned them, kind of left them on their own in some ways. So we're really not being honest in this discussion. We on the medical provider side of things have, not been fair to these mothers. We have told them, only gloom and doom. We have not offered them this palliative care option in an honest way. So of course the general public thinks that abortion is indicated in these scenarios because we as medical providers are guilty of telling them that that's the only option they have. And again, that is pro-abortion, that is not pro-choice. To be fair, we need to be honestly walking mothers through the two options they have and discussing again in detail what these options actually mean. Does the mother understand that her baby can feel pain, and how this abortion will be carried out? Does the mother understand that she has the option, to pursue palliative care for her child? And that we will honor her wishes. We will work with her in coming up with a plan that honors her and her baby. Again, parents who I've, directly worked with who have chosen the palliative care option, again, voice the same thing that statistically the literature supports, which is appreciation for us treating their child like a human being. For allowing them to continue to see the baby's heartbeat, to watch the baby grow and develop, and again at the time of delivery that they have the support they need to say goodbye to their child, and they know that they did everything they could for their child. They express an appreciation for the fact that we supported them in doing everything that was, that we could within our power to prevent the baby from suffering, and to experience, a peaceful, natural passing, again, for the babies who aren't able to benefit from medical support. So statistically, these mothers do much better psychologically. Again, of course, this is a difficult situation, but it's a difficult situation from the moment of diagnosis. Abortion really does not alleviate the mental suffering and anguish that a mother feels. And again, lots of women talk about, again, their choice to terminate was something that, they really struggled with, even years after the abortion. So abortion really doesn't cure the baby. It doesn't fix the fact that this is a tragic situation. Um, Again, these situations are tragedies from the moment of diagnosis. But we know that choosing palliative care for many of these mothers can actually be a very healing and helpful thing, in processing, the death of the baby, and knowing that they did everything that they could to support the baby through the passing.
Yes, absolutely. And I think it really strikes me that any society where abortion is legal and is offered to women, it's always such an an abandoning of women, and it's such a way of deceiving them, because every time we say it's legal, it's offered, we're saying that, okay, we might acknowledge that this is a hard path to go down, but we're still saying this is legitimate, and even if it's hard, it's a legitimate path for you. And I think this is really so dangerous when societies do this, and it's truly not standing by women in these really difficult situations, who wouldn't consider this if it wasn't being offered, if it wasn't legal. So I think it's really a really dangerous situation when we have this institutionalized in societies. And with regard to abortion being oftentimes spoken of as a medical procedure, it's not only nowadays with regards to life of the mother, terminally ill children, but it's getting more and more radical. I mean, in and of itself, a view which calls for the taking in of an innocent life is radical, but it just gets more and more so because now it is abortion is healthcare, period, right? And even though, right, pregnancy is not a disease, it's not an illness, it's a healthy occurrence in the body, and it seems extraordinary to, by any stretch of the imagination, to call this healthcare. What is your answer to this?
Yeah, and actually that may have been a good kind of way to start off this segment. That's a really important point to make. So again, looking at the medical literature, there is an organization called the Guttmacher Institute, which reports on abortion statistics. And again, they're a pro-choice organization. And even they have acknowledged over and over again, over 98% of abortions are done for reasons that have absolutely nothing to do with medical concerns for the mother or for the baby. So again, we're talking about 98% of abortions have nothing to do with all of the tragedy that we just talked about. Even when it comes to late-term abortions, again, that's a definition for an abortion that occurs after about 21 weeks gestation, which is again around that time of viability where the baby could potentially survive outside of the womb with medical support. Even the majority of late-term abortions are, again, done on healthy moms carrying healthy babies that have nothing to do with concerns for her health or for the baby's health. They looked at even, again, comparing statistics from I believe it was 1987 and 2004, something like that. Again, it's only 1% to 2% of women would say that their abortion had anything to do with any concerns for either their health or the health of their, the baby that they were carrying. So, you look at late-term abortions, statistically, yes, the percentage is small. However, again, at 1.5% or so, done that late in pregnancy after 21 weeks. But again, we're still talking about 10,000 babies per year who are potentially viable, who are healthy, who are being carried by a healthy mother, who are being killed through abortion procedures that, again, have nothing to do with concerns for the, medical concerns for the mother or for the baby. So, every time, these kind of arguments come up, we need to put them into context, which is even the late-term abortions are still being done for elective reasons, having nothing to do with medicine. We know that, again, that majority of obstetricians do not do abortions, again, because abortion is not healthcare. We can manage pregnancy complications in life-affirming ways. Again, the American Association of Pro-Life OBGYNs is such an incredible resource. Again, these are a group of, medical professionals, OBGYNs. This is what they do all day long. And again, the difference between a pregnancy complication resulting in the natural death of a baby is incredibly different than, inducing the death of a baby. And again, is never medically indicated, even in the cases where we have medical concerns for mom, we have medical concerns for baby. There's ways that we can manage those pregnancies that do not involve an abortion procedure.
Yes. Gosh, well, this has been such an incredibly informative conversation, really on just so many of the core misunderstandings in this area. So I'm just so grateful that you've been speaking to us today and really shedding a light on what is really at stake here, what is really needed to provide true medical care to both the mother and the child in all situations. So, Dr. Kolb, thank you so much for coming on the show today.
Absolutely. Thank you so much for having me.